Accurate diagnosis will lead to precise treatment and the patient's life will be improved. With that, let's check out infective endocarditis diagnosis. We'll be going through two major processes: microbiology in the lab, radiological investigations involving echo, cardiac, CT, MRI, chest X-ray, and so on. Without wasting your time, let's get into the business. Infective endocarditis diagnosis. Now, making definitive diagnosis of infective endocarditis through microbiology will be the first chapter to be considered. Sit back and let's go. The hallmark of infective endocarditis is the presence of inflammatory changes in valvular tissue at the site of vegetation attachment. Also, fever will continue as long as there is bacteremia. Generally, it is important, actually compulsory, to know the culprit, and the diagnosis can take us through three different areas. Clinically, we can take history, clinical features, signs and symptoms, physical examination, particularly peripheral stigmata of infective endocarditis through the hand. You can see the heart through the hand, right? And of course, the risk factors. We should know all these. Then we'll head to lab. That is where we are right now. Microbiology, then later on, cardiac enzymes to rule out myocardial infarction. We've gone to radiological investigation, echo, CT, and the rest. Check my channel for that. So back to the point. Today is all about laboratory diagnosis using microbiology. The initial considerations. When can we obtain sample? When we are likely going to embark on empirical treatment or definitive treatment. The first factor is whether the patient is stable or unstable. Stable patient, yeah, you can take the sample before giving any antibiotics or before starting any empirical treatment. But the unstable patient, if you can do it quickly enough to obtain the sample, but don't, because you want to obtain the sample, then keep the antibiotics away. No. But even if your center is not so equipped with so many hands to help, within 48 to 72 hours of the onset of empirical antibiotics, you can obtain the sample. Then, you can repeat MCS after if there is need for that. And of course, you will do as you continue with definitive treatment. Now, let's get to the business proper. Microbiology study here will be through blood culture. 3 sets of blood culture will be needed. A set will be of 2 bottles, one for aerobic and the other for anaerobic microorganisms. How to take the sample and the time apart. Take the sample before giving antibiotics if the patient is stable. Even in an unstable condition, if you have many hands, one person can be taking the sample while the other one can be administering the intravenous antibiotics empirically. 10 ml of blood is needed in each bottle. Each sample should be taken from a separate vein site. No regard to temperature or time of the day. You can take it at any time. Well, the best is take it immediately you are able to once the patient is with you. Take each sample at least 12 hours apart. You know, we are going for 3 sets, right? Most agents will be dictated now at 48 hours, but HACEK group is fastidious, so may be dictated within 5 to 7 days. If prior antibiotics has been given, we will need more cells. So we will need additional 2 to 3 cells over 5 days. Can we go through the list of possible microorganisms? Yeah, but I won't do that here right now. There is a separate full presentation on that already published. Here is the link. Actually, some authors will, from the beginning, call infective endocarditis bacteria endocarditis. Why would they give the name bacteria endocarditis? Because 80 to 90% of the times, infective endocarditis will be caused by bacteria. So you can get the details here of all microorganisms that could cause infective endocarditis. But let me quickly brush through some common bacteria that will be involved. Staphylococcus aureus, Streptococcus viridans, or Staphylococcus galolyticus, that is formerly known as S. bovis. HACEK group, or commonly acquired enterococci, could all be involved, in addition to fungi, and the list goes on. Just go through this thing, you understand better. If somebody will ask me, can we have false positive? The answer is yes. We can have false positive with Cotibacterium, formerly known as Propionibacterium acne. We can have false positive with Bacillus species, also with coagulase negative Staphylococcus, and also with Corynebacterium species. What if the culture is negative? And we'll be dealing with culture negative infective endocarditis. Yes, that is pretty true. We can have culture negative infective endocarditis if after 5 days of incubation, all the 3 cells have been returned and all negative. Then we should think about some issues here. Number 1, has antibiotics been given and that has prevented the growth of the agents? Or we are dealing with fastidious agent with fastidious characteristics that will demand more to grow, right? Or we have intracellular bacteria that cannot be cultured with the standard methods. But something will remain, even in the face of all these probabilities. The fever will be persistent. The echo would have confirmed the presence of vegetation, probably the presence of abscess, intracardiac abscess. In some, they would have likely come down with complications like stroke, and physical examination would have proven that the peripheral stigmata of infective endocarditis is right here. You'll be able to see the heart through the hand, right? And of course, cardiovascular examination would have established a new heart murmur, and some will already be done without failure. Then, what else are we going to do? Let's go. If we have culture negative infective endocarditis, what other laboratory investigations can we have done? Yes, we can have serology, we can have polymerase chain reaction done. Okay, I agree. It is infective endocarditis and it is culture negative. What are the possible culprits here? Yeah, could be chlamydia, legionella, mycoplasma, brucella, bartonella, or Coxsackia bonentis species. They could be responsible for culture negative infective endocarditis. Another question is, what other investigations can we embark upon if we are faced with culture negative infective endocarditis? We can have histology done, histology of the vegetation that is seen on echo, or that that of intracardiac abscess. And of course, we can have resected valve. Now, under a very strong suggestion of infective endocarditis, we can have resected valve cultured. Finally, I will conclude the way I started because it's pretty important. We should know the time to obtain the sample in relation to empirical and definitive treatment. If the patient is stable, we can buy time. We can take the sample, then we'll be doing other stuff like taking, for echo and giving empirical treatment as the case might be. But we don't have the luxury of time in an unstable patient. So if we have more hands, while one person is preparing the intravenous antibiotics, the other should be taking the sample for microbiology study. However, if we are forced to a corner, we don't have enough hands to do that at the same time, then within 48 to 72 hours of the onset of empirical intravenous antibiotics, we are fine to still take our sample, and we'll repeat the sample as we continue in the treatment. When the lab result is back, we'll then review with the lab result and embark on definitive treatment. But we must never make that mistake of holding the empirical intravenous antibiotics simply because we would like to have the sample taken. Thanks for listening. Remember to share this with your friends on your platform. Remember to subscribe to my channel. I appreciate it. Now, I will be going through how to make the diagnosis of infective endocarditis using cardiac imaging. We've gone through the microbiology because later on you'll be talking about modified Duke criterion. The major criteria will be focusing on blood culture and findings on echo. So, cardiac imaging in infective endocarditis. Echo. We can have transthoracic echo or transesophageal echo. Most of the times, we'll start with transthoracic echo. And then we'll follow up with transesophageal. But sometimes we can go straight to transesophageal echo. When do we need echo? Once infective endocarditis is suspected, then we'll go for the echo. Here's the question. Is it possible to have echo-negative infective endocarditis? Yes, it is possible if the vegetation is too small or if the vegetation has already embolized. You can have echo-negative infective endocarditis. What will echo reveal? Echo will reveal valvular dysfunction, hemodynamic severity, ventricular function, the presence of shunts, and while following up in the face of bacteremia and deteriorating patient that's on treatment, echo will guide blood. Echo is said to be positive for infective endocarditis when it is revealing vegetation or there's an abscess or both, or when prostatic valve is showing dehiscence. So we can say that the echo is positive for infective endocarditis. Is transthoracic echo the first to be employed? Yes, in most cases, the transthoracic echo will be the first to be ordered. And then we'll be looking for vegetation, but the absence of vegetation will not probably rule out infective endocarditis. So it doesn't mean there is no infective endocarditis if transthoracic echo cannot pick vegetation. The chances of infective endocarditis is lower when transthoracic echo is revealing a normal valve with normal function. Is transesophageal echo superior to transthoracic echo? If that is the question, the answer is yes, it is superior to transthoracic echo. And let me tell you some facts about that. Transesophageal echo sees valvular perforation, can see the abscess of fistula, even aortic pseudoaneurysm. We must have transesophageal echo once TTE is positive. Even if TTE is negative, but with a high suspicion for infective endocarditis, then we must embark on TEE. If TTE is inadequate, then we must do TEE. TTE is positive and you have treated the patient, but you're not winning, then do TEE to know exactly what's going on. TTE is showing valvular regurgitation, and then you need to make up your mind whether or not surgery will be required, then have TEE done. So TEE is more superior to TTE. Is it possible to have false positive TEE? Yes, it is possible. We can have false positive transesophageal echo when there's cardiac tumor, when there's mural thrombus or fibrous strands on aortic valve. You need to have TEE, but there is pacemaker and fever. Regardless of the outcome of TTE, we must have TEE done if anyone is on pacemaker and at the same time having persistent fever with or without murmur or bacteremia. We must have TEE done. The question can be that is it possible to skip TTE and have TEE done directly? The answer is yes. You can jump TTE and go straight to have TEE as a first echo to be done when the individual is already known to have infective endocarditis in the past. So previous infective endocarditis can warrant TEE as the first echo today. Also, when there is past valvular abnormality, then you can have TEE done as the first echo. Lastly, when TTE is difficult because the individual is endowed, meaning obesity, or chest wall deformity is constituting hindrance, or mechanical ventilation is in situ, then you go straight for TEE. Another question is, can we have a repeat TEE? Yes, we can when the TEE that has been done previously has come out to be negative, but you are so pressed with high degree of suspicion in this patient who are presented with persistent fever and peripheral stigmata of infective endocarditis are just so obvious. Or there is no other cause or causes of the persistent fever that you are dealing with right now, and neurocrine features or complications are already showing forth. Then we will repeat TEE at least 1 week after the first TEE. Now, cardiac CT. When will cardiac CT or fluorodeoxyglucose positron emission tomography become necessary? Yes, if both TTE and TEE are non-diagnostic, then we have the alternative, that is the cardiac CT. Fluorodeoxyglucose positron emission tomography with CT will also be helpful when planning for surgery in patients with extravalvular complications. Cardiac CT is more informative than echo when TEE is precluded by artifact. Cardiac CT will be a better option. Cardiac CT is superior to TTE and TEE for paravalvular extension of infection and abscess. For the evidence of embolization, CT of the head and chest will be better. Though cardiac CT is fine, but not without demerits or not without shortcomings. And the shortcomings here will be that transesophageal echo, that is TEE, is better than cardiac CT to diagnose vegetation. Other radiological investigations that we can make use of will include EKG, and of course elementary with serial EKG. And you know what I'm trying to rule out, right? Then we can have chest X-ray. This will add cardiac enzymes to this, but I'm limiting this presentation to radiological investigation. We can have chest X-ray when we're suspecting septic emboli of the pulmonary system. Also, the infiltrate with or without cavitation. And of course, that will help with congestive cardiac failure. Then we have non-cardiac CT of the chest, abdomen, and pelvis, because we might be concerned about metastatic infection, like going to the splenic vascular supply, giving splenic infarction, renal infarction, Suarez abscess. Then that will help us to determine the need for a localized drainage. And lastly, magnetic resonance imaging. This will be helpful to rule out certain complications like vertebral osteomyelitis. Remember, if vertebral osteomyelitis is involved, the individual will be on antibiotics for a very long period. And also, MRI can help with intracranial mycotic aneurysm. I have a several presentation on mycotic aneurysm already published. Also, central nervous system bleeding. If there is associated headache or neurological deficit, with or without meningeal signs, magnetic resonance imaging can help greatly. With that, I've come to the end of radiological investigations when it comes to infective endocarditis and some possible complications of the same. Thanks for listening. Please remember to subscribe. Remember to share this on your platform. I appreciate it. In conclusion, I have made this presentation in such a way that has made it very easy for anyone to revise. And also, you can check for modified due criteria on this channel. It's already been published. Other topics on infective endocarditis could be checked here, like risk factors, prevention, treatment, and even complications. With that, I'm rounding up on how to make diagnosis of infective endocarditis. You're free to leave your comments. Please remember to share this on your platform. Remember to subscribe to my channel. I appreciate it.